Head of the Department of General Surgery at Little Flower Hospital, Angamaly. And the case is presented by Dr. Jasmina VP, Family Medicine Resident at Little Flower Hospital, Angamaly. Welcoming you all to the session. And over to you, Jasmina.
Good evening, all. I'm Dr. Jasmina, Family Medicine Resident at Little Flower Hospital. Thank you for this opportunity. And can I start with the case? Am I audible?
Yeah, you are audible.
Can I start with the case?
So, Amudhan sir, can you start? Can we start?
Yeah, please. Go ahead, Jasmina.
Okay, sir. My patient, Mrs. XYZ, 32-year-old female, studied up to degree, a homemaker, residing at Kalamassery, belonging to upper middle class family according to modified Kuppuswamy's scale. Her husband name is Mr. XYZ and businessman. She presented with swelling over the front of neck since 2 years. And history of presenting illness, patient was apparently normal 2 years ago when her relatives noticed a swelling over the front of her neck. Insidious in onset, gradually progressed from initial size of 3 into 2 centimeter to present size of 5 into 4 centimeter. There is no complaints of fever or pain, no history of change in voice, difficulty in swallowing, noisy breathing, breathlessness or fainting. No history of loss of weight in spite of good appetite, heat intolerance, diarrhea, irritability, tremors of hands, sleepless nights, palpitation, chest pain, breathlessness, bulging of eyes, double vision. No history of weight gain despite of reduced appetite, constipation, lethargy, cold intolerance. No history of swelling elsewhere in the body, bone pain, breathlessness, cough, hemoptysis, seizures. Past history, note a non-case of diabetes, hypertension, tuberculosis, asthma, seizure disorders, or cardiovascular disease. No history of previous surgery in the neck or prolonged radiation exposure to head and neck region. Drug history, no history of use of thyroid-related medication, no known drug allergy. Personal history, she consumes mixed diet, has good appetite, her sleep is undisturbed, and her bowel and bladder habits are normal and regular. No addictions. Family history, no history of similar illness in the family or neighborhood, no history of cancer-related death in the family or thyroid illness in the family. Menstrual and marital history, attained menarche at the age of 13 years, LMP was March 21st, 2026. She had a regular cycle of 28 to 30 days. She married at 16 years back and has 2 children. Both are normal vaginal delivery. Summary, 36-year-old lady with complaints of...
Charging zup అయిపోతుందని నేను వాడేప్పుడు.
Can I continue?
Yeah, please continue.
36-year-old lady with complaints of swelling in the front of neck since 2 years, insidious in onset, gradually progressed to present size of 5 into 4 centimeter without any symptoms suggestive of hypothyroidism or hyperthyroidism.
Dr. Jasmine, I'll just stop you at this level.
Okay.
See, this symptoms of hypo and hyperthyroidism, it is enough if you just tell there are no symptoms of hyperthyroidism. Otherwise, it will become a big lecture. And if the examiner asks you what are the symptoms of hypo and hyper, then you can elaborate on that.
Okay, sir.
And then again, for hypo and hyperthyroidism, menstrual history comes there, not as a separate part.
Okay, sir. Okay.
And constipation, bowel again comes in hyper and hypo.
Okay, sir.
You'll have amenorrhea in hyper and oligomenorrhea, menorrhagia in hypothyroidism. All this should be mentioned in symptoms of hypo and hyper.
Okay, sir.
Yeah, go ahead.
Coming to general physical examination, after explaining the procedure, verbal consent obtained and examined in well-lit room in sitting position with adequate exposure in the presence of a female attendant. Middle-aged lady, moderately built and nourished, comfortably sitting, BMI 24.6 kilogram per meter square, conscious, oriented to time, place, and person, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Skin, hair, nail appears to be normal. Her pulse rate was 84 beats per minute, regular rhythm, normal volume and character, no radial or radiofemoral delay. Blood pressure 110/80 millimeters of mercury in right upper arm in sitting position. Temperature 98.6 degree Fahrenheit. Respiratory rate 16 cycles per minute. Saturation 98% in room air. Local examination on inspection. She was examined in sitting position with neck extended. A solitary thyroid ovoid-shaped swelling measuring about 5 × 4 centimeter in the anterior aspect of neck towards the right side of midline, extending superiorly below thyroid cartilage, inferiorly 2 centimeter above sternal notch, horizontally from 1 centimeter medial to anterior border of right sternocleidomastoid to the midline in the left side. The swelling moves with deglutition but does not move with protrusion of tongue. Well-defined borders, lower border is visible, surface appears to be smooth, skin over the swelling appears to be normal, no discoloration or dilated veins or scars, no other swelling in the neck, trachea appears to be central. Examined in the sitting position with neck flexed, standing behind the patient. On palpation, no local rise of temperature. There is a non-tender ovoid-shaped swelling in the anterior aspect of neck, which moves with deglutition and extending superiorly below thyroid cartilage, inferiorly 2 centimeter above sternal notch, horizontally from 1 centimeter medial to anterior border of right sternocleidomastoid to the midline in the left side. All borders are well defined. Lower border is palpable, firm in consistency, mobile in vertical and horizontal direction. Swelling is deep to deep cervical fascia. No thrill in the upper border of swelling. Trachea central. Carotid pulsation palpable at the usual site. Cervical lymph nodes not enlarged. On percussion, resonant note heard over manubrium sternum. Auscultation, no bruit heard over the upper pole of swelling. The systemic examination, cardiovascular system, S1, S2 heard, no murmur. Respiratory system, normal vestibular breath sound heard, bilateral equally in all areas. No added sounds. Abdomen soft, non-tender, no organomegaly. CVS, no focal neurological deficit. Summary, 36-year-old lady with complaints of swelling in the front of neck since 2 years. Insidious in onset, gradually progressed to present size of 5 × 4 centimeter without any symptoms suggestive of hypothyroidism or hyperthyroidism. On examination, non-tender ovoid-shaped thyroid swelling in the anterior aspect of neck towards the right side of midline, which moves with deglutition, measuring 5 centimeter horizontally and 4 centimeter vertically. All the borders well-defined, lower border palpable, smooth surface, firm in consistency, mobile in horizontal and vertical plane. And my professional diagnosis is solitary nodule in the right lobe of thyroid, probably benign and clinically in euthyroid state.
Yeah. Can you go to the examination, the general physical examination slide?
Okay, sir.
You mentioned about BMI, but I guess I don't know about family medicine, but for the specialties like general surgery, they also expect you to mention about ECOG score.
Okay, sir.
ECOG is, you know what ECOG is?
No, sir.
ECOG is a Eastern Cooperative Oncology Group scoring, 0 to 5,
Okay,
where
sir.
0 is fully active and 5 is deceased. You can just read up that. So in
Okay.
case they ask you, you should be in a position to answer.
Okay, sir.
And the next slide, please. The next one. Okay, next one. Next slide, next slide. Why do you say this is a thyroid nodule? Why do you say this is a thyroid swelling?
One thing is, it's in the usual site of thyroid gland. In
You
the
say it is the region of the thyroid.
region of thyroid, and it
Okay.
moves with deglutition and does not move with protortion of tongue.
Okay.
And on
Why
palpation,
does the thyroid swelling move with deglutition?
because the pretracheal fascia encloses the thyroid gland, it is attached to the cricoid cartilage through the suspensory ligament of Berry.
Okay.
So whenever there is laryngeal movement during deglutition, thyroid also move upward.
Okay. What is pretracheal fascia?
It is a layer of interesting layer of deep cervical fascia.
Pretracheal fascia is the investing layer of deep cervical fascia. That's what you said.
No.
Okay. The deep cervical fascia is again, it has three parts. The first one is the investing layer of deep cervical fascia. The next is pretracheal. Then the lowmost part is the prevertebral. So the pretracheal is the one which covers the thyroid, esophagus, and the trachea, and also forms the Berry's ligament. Why does the thyroid swelling not move with protrusion of the tongue?
Because it is not attached to the like foramen cecum. The structure which is attached to the foramen cecum will be moving with protrusion of the tongue.
Yeah, which
Usually
structure is
it is
attached?
thyroglossal cyst, usually attached to foramen cecum and will be extended to the infrahyoid region.
Okay. And what are the swellings move with deglutition other than thyroid?
Level 6 lymph node move with deglutition. Thyroglossal cyst move with deglutition. Sometimes dermoid cyst can also move with deglutition.
Subayard bursitis is another one.
Okay, sir.
How do you make out whether there is any retrosternal extension of the thyroid gland?
One thing is when we on inspection, when we ask the patient to swallow, usually if there is no retrosternal extension, we'll be able to see the lower border, and on palpation also we'll be clearly able to palpate the lower border. So if we are not able to palpate the lower border, usually there will be retrosternal extension. And on percussion of manubrium sternae, it will be dull if there is retrosternal extension.
Okay. You heard anything called a Pemberton sign?
Pemberton sign, when we ask the patient to lift the both the arms above the head, there will be congestion of the face. In case of retrosternal extension, there will be this SVC will be obstructed, and that will lead to congestion of the face, and dilated neck veins can also be seen. It is known as Pemberton sign.
Okay. And on palpation, you're also supposed to mention about carotid pulsations in the case of thyroid.
Okay, sir.
So what is Berry sign?
Berry sign is absent carotid pulsation. It can be seen either when there is a large thyroid swelling, the carotid pulsation can be like deviated, and we will not be able to palpate it in the usual site, that is in the anterior border of sternocleidomastoid at the thyroid cartilage level. And in case of infiltrated carcinoma also, will not be able to palpate the carotid artery pulsation.
Okay. So your diagnosis is a solitary nodule thyroid.
Yes, sir.
So how do you proceed?
First thing is thyroid function test. We have to know whether the patient is biochemically euthyroid or not. Then we will go for ultrasonogram of neck to rule out any features of malignancies there. And then we can also go for FNAC. Usually,
When do you go for an FNAC?
if there is features of malignancy in the ultrasonogram, we can go. Or biochemically, if the patient is euthyroid or hypothyroid, then also we can go for FNAC.
Okay. See, in a case of multinodular goiter, like what you mentioned, we do an ultrasound. And then based on the findings that you see on ultrasound, like TIRADS 1, 2, 3, 4, and 5, there are definite indications for an FNAC. However, in the case of solitary thyroid nodule, we almost always do an FNAC to rule out any malignancy. Because it's only going, if at all thyroid, solid nodule thyroid of this size, anyhow, we are going to offer the patient a hemithyroidectomy.
Yes.
But that is not the case with multinodular goiter. When do you offer surgery in a case of multinodular goiter?
One thing is if it is huge size and leading to compressive symptoms.
Okay.
Second thing is it can lead to hyperthyroidism, like toxic nodule-like features, or in case of cosmetic purpose also we can do surgery. Then long-standing large multinodular goiter can progress to transform to malignancy. So long-standing multinodular goiter also we offer surgeries.
Okay. Is there a differentiation? Is there a criteria based on the size of the nodule?
5 centimeter, right, sir?
No, usually more than 3 centimeters is what we say. But how do you follow up a case of multinodular goiter? If you're not offering a surgery, what do you do? How do you follow up that case?
One thing is we have to check the thyroid status, biochemical status. Then at least every 6 months we have to do ultrasonogram to know whether there is any malignant transformation happening or rapid increase in size also.
No. You won't do it every 6 months. Annually or once in 2 years is more than enough.
Okay, sir.
It's not going to increase in 6 months' time. If the patient is euthyroid and it is just an MNJ on ultrasound, you can just do it annually.
Okay, sir.
And when do you do an FNAC in a case of? See, this is more important for you because you have worked with us in the Department of Surgery. You know that whenever somebody sees a thyroid swelling on ultrasound, it's immediately referred to the surgeon.
Yes, sir.
So, and then they ask for an FNAC. You should know when to refer to a surgeon and when to do an FNAC. On ultrasound of the thyroid, what they usually mention is TIRAD scoring. TIRADS 1, 2, 3, 4, 5. TIRADS 1 is a benign swelling. 2 is no suspicion of malignancy. 3 is mildly suspicious. 4 is moderate suspicion. And 5 is highly suspicious. So in a case of TIRAD 1 and 2, you don't have to do an FNAC at all.
Yes, sir.
And in the case of TIRADS 3, if the swelling is more than if the nodule is more than 2.5 centimeters, you do an FNAC.
Yes.
If it is less than 2.5 centimeters, like I said, you follow up the patient every 2 years with the ultrasound. Whereas in the case of a TIRADS 4, if the swelling is more than 1.5, you do an FNAC. And in the case of TIRADS 5, what the literature says is more than 1 centimeter, but even otherwise, when it's TIRADS 5, we do an ultrasound guided FNAC to rule out a malignancy because the chances of malignancy in a TIRADS 5 lesion is more than 35%. Okay. So you do a, what did you say? How do you say, what did you say you'll do with this patient? You said a thyroid function test, ultrasound, then FNAC.
Definitely.
Okay.
And based on the report, we will offer hemithyroidectomy.
Okay. So what is hemithyroidectomy?
One lobe of the thyroid and isthmus is removed. That is hemithyroidectomy, and the opposite lobe will be conserved.
Okay. And what does usually, what do you see on FNAC in a case of solitary thyroid nodule?
Sorry, sir.
What will FNAC tell you?
Adenomas,
Sorry?
thyroid adenoma or colloid goiter.
Okay.
Or it can be thyroid cyst as well.
Okay. Thyroid adenoma meaning, what did you mean by thyroid adenoma?
Follicular adenoma.
So what do you do with that? You do an FNAC on this patient, it comes as a follicular adenoma. Or you do a FNAC on this patient, it comes as a colloid goiter. What do you do?
We can go
Colloid
for
nodule.
hemithyroidectomy, sir.
Why?
One thing is size is large.
Okay.
With small size, we can manage conservatively.
Fair enough. The size is large, you offer the patient a hemithyroidectomy. What if it's a thyroid cyst?
Thyroid cyst aspiration can also be done.
No, when you do an FNAC, you would have aspirated by then. If it's a thyroid cyst, you will anyway aspirate, so it will disappear. So how do you manage the thyroid cyst?
Conservatively.
How? Conservatively meaning? You do an FNAC and same setting, you aspirated the swelling. It disappears. So the patient comes back with a cystic swelling again. What do you do? Thyroid cyst, they say that we can aspirate at least for 3 times. And if it keeps recurring more than 3 times, you can offer the patient a lobectomy or a hemithyroidectomy.
Okay.
So coming back to your follicular adenoma, you do an FNAC and it comes as a follicular adenoma. How do you manage?
Hemithyroidectomy we can do, sir.
Why?
In this patient or
Not in this patient. You have a patient, say 2 centimeter nodule, and
then
you
we
do an
can
FNAC.
conservative and follow up and
What is the drawback of FNAC in the case of thyroid swelling?
we cannot differentiate from follicular adenoma and carcinoma.
You said then you'll follow up this patient. Why
Then-
cannot you differentiate between adenoma and carcinoma?
Because only the tissue is taken, individual cells are not taken.
No. Think. Tissue has cells, no?
Cyst wall is needed.
Cell,
mean,
cluster of cells only form a tissue. You have a tissue there, you have a tissue biopsy there, which has lot of cells in that, and it shows adenomatous growth, follicular pattern. So that's why you call it a follicular adenoma. So what is carcinoma then? See, the differentiation between a follicular adenoma and carcinoma can be made out only if there is a capsular or a vascular invasion, which cannot be made out on an FNAC. So if it comes as a follicular adenoma, you offer the patient a hemithyroidectomy, and depending on that, if it comes as a carcinoma later on, even if you do an hemithyroidectomy for a patient comes as a papillary carcinoma, then you go back and do a completion thyroidectomy. Okay. And what are the high signs associated with thyroid?
Eye signs.
Name a few that you know.
One thing is stalwart sign, starey look due to ophthalmos, exophthalmos, and other thing is Mobius sign, difficulty in converging the eyes. Then von Graffi sign. Then Dalrymple sign. Lid retraction and lid lag.
Okay. A patient with a solitary nodule thyroid or say multinodular thyroid, 1.5 centimeters, the largest nodule. Do you treat the patient with Eltroxin?
Sorry,
Patient
sir?
is euthyroid. The patient is euthyroid. Patient is euthyroid as a small solitary nodule. Or the patient is euthyroid as multinodular goiter. The largest nodule is about 1 centimeter. Do you offer the patient Eltroxin?
No, sir.
Okay. Why does a multinodular goiter occur?
Some part of the thyroid is hyperreactive and some part is not normally functioning and some part is hyperreactive. I mean hyporeactive.
Okay. See, what happens is in situations like pregnancy, when there is a pregnancy and when situations where there is less thyroid, like in iodine deficient areas, the deficiency of thyroid hormone causes a surge in TSH production. So there is overstimulation of the thyroid and there is actually a diffuse goiter to start off with. Then when the stimulation comes down, there is a differential stimulation that doesn't come down fully. There a part of the thyroid is stimulated, the other part is not stimulated. The part that is stimulated grows to a larger size, and then it has a central necrosis and all that. This central necrosis forms a colloid nodule, and the surrounding tissue is the normal active thyroid. Did you get what I told you?
Okay, yes, sir.
Yeah. So that where do you see MNG?
Sorry, sir.
What is the etiology for MNG? Where do you see?
Iodine deficiency.
Okay.
Um,
Etiology for goiter. Forget MNG. Etiology for goiter. Thyroid swelling.
Middle-aged females.
Okay. No, not about females and all. Where do you see this thyroid swelling? I put thyroid. I mean iodine deficiency. You said otherwise. History. What all are you supposed to take? We ask about the patient's location
Then
because it's in hilly
microsis,
regions where there is
diet
iodine
history,
deficiency. Sorry.
diet history,
Why?
goitrogens leading to
Like?
cabbage, cauliflower, and all, Brassicaceae family.
Okay. Then.
Then pregnancy,
Okay. Then. Diet and pregnancy. What else? Is location important? I just told you the answer also.
yes, sir.
Why?
Endemic areas where there is iodine deficiency,
Like?
hilly areas.
Okay. Then what else?
Mm,
Do you ask any history of radiation in the past?
yes, sir.
How does it matter?
Radiation to the neck can later in the life lead to papillary carcinoma thyroid.
Okay. So the patient with patient with the thyroid swelling with history of radiation, you suspect a papillary carcinoma. If at all you think it is a malignant lesion. And in a
Yes.
long-standing goiter, you usually suspect a follicular carcinoma.
Yes.
Okay. And how do you examine a thyroid gland?
Like local examination.
Yes.
On inspection, we will examine, we will explain the procedure and take consent.
And in an exam, the examiner asks you something, don't say we. You're the one who is going to talk.
Okay, sir. Okay, I will explain the procedure and take consent.
Okay.
If in front of, in the presence of an attender, we will examine with adequate exposure.
Okay.
And
No,
then
forget all that. You tell me the examination of the gland.
So in front of the patient, I will stand, and then if slight extension of the neck will lead to greater visibility, and if there is short neck and obese patient, I can also ask them to do Pisilo method, where I ask the patient to clench the hand, keep it over the back of occiput so that the thyroid gland will be more visible. Then look for a movement on deglutition on inspection. Then look whether the lower border is palpable, whether it is smooth or not. And to on palpation, usually we will stand behind the patient, and with the fingers we will palpate the thyroid gland. And to palpate the lateral borders and each lobe separately, Lahey's method we can use. With one hand, we will press the one lobe, and with the other hand, we can feel the other lobe. And for checking the nodularity and all, we can use Kreil's method, where we use the thumb. And anything else?
Yeah, that should be okay. And what surgery do you offer? If at all you offer surgery in a case of multinodular goiter, what surgery do you do?
Total thyroidectomy, sir.
Okay, not subtotal.
No, sir.
Why?
The chance for a recurrent surgery is high.
Good. Okay, good. Yeah, I think they should be enough. You should concentrate more on stuff like the examination points. How do you examine a thyroid, like the Kreil's method and all that you told? Pemberton's sign, high signs, and FNAC ultrasound findings. The surgical steps I don't think is required for you. Okay.
Okay, sir.
And the other thing is, this is okay because there are a lot of other family medicine residents here in the group listening to your presentation, but try and not read from the slides.
Okay, sir.
This presentation you have made at home and come, you're answering, so it means you come prepared. That's a different thing. But then even in the exam, sometimes they give you the paper to read it from, but you have to write in the exam, no? Only if you know, you'll write. So try not to read from the paper.
Okay, sir.
Okay,
Thank you, sir.
that's a good presentation. All the best.
Thank you, sir.
Anything else, or do we stop here?
Good evening, everyone. Myself, Dr. Kiran, Secretary, Spice Road, Kerala. On behalf of whole team of Spice Road, Kerala, I extend my heartfelt vote of thanks for today's session. Firstly, I express my sincere gratitude to respected Amudhan sir for guiding the session and for sharing the expert insights. Sir, it really added a great value to our learning. I would also like to express my appreciation and gratitude to Jasmine for delivering such a clear and clinically relevant case session. Finally, a special word of thanks to all the participants who joined with us today. We look forward for your continued participation in all future sections. Thank you and have a great evening. Thank you, sir.
Thank you. Somebody asked about a radioisotope
Sorry for the
scan.
interruption, sir. There is a doubt in the chat section, sir.
Yeah, that's what. Somebody asked about a radioisotope scanning. It is, as of now, not done. Earlier, it used to be a investigation of choice for almost all thyroid swelling. They used to grade it as cold nodules, hot nodules, warm nodules, and all. But of late, this radioactive iodine scanning is not done. It's usually done only for a toxic nodule in a multinodular goiter. Only in the case of a toxic nodule. Otherwise, radioisotope scan is not indicated anymore. Any other doubts?
Participants, please please ask any doubts if you have.
And this again, this toxic nodule that I was telling you about. A patient has an MNG multinodular goiter, but has hyperthyroidism. One of these nodules is overreactive. And that is a clear indication for a thyroidectomy. Usually in an MNG, if the size is around less than 3 centimeters, I usually don't offer surgery because thyroidectomy, again, is a major surgery. The risk of injury to the parathyroid, risk of injury to recurrent laryngeal, external laryngeal, all this is there. So usually, nodule less than 3 centimeter can be left alone if there are no compressive symptoms, if the patient is euthyroid. But in a case of hyperthyroidism, in a patient in a case of MNG with hyperthyroidism, always offer the patient surgery. This is secondary hyperthyroidism. Always offer the patient surgery. You don't have to actually do a radioisotope scan. You can go ahead and offer the patient surgery. And you will have to know about the complications of thyroidectomy. Injury to the recurrent laryngeal nerve, injury to the external laryngeal nerve, and all that. Anything else?
I think there is no further doubts in the chat section, sir. So
Yeah. Okay then. Thank you so much.
thank you, sir. Thanks a lot, sir.
Thank you.